Stop. We are live in 3, 2, 1. Please start. Stop. We are live.
Very good evening, all distinguished delegates and our eminent speaker for today, Dr. S.K. Agarwal, sir. I am Satish Rama Joshilkar from Zydus Medica. Is honored to welcome you all for the scientific platform called CLEARTalk. On behalf of Zydus Life Sciences, I would like to express my most sincere gratitude for your presence in this scientific webinar. Giving a brief introduction about CLEARTalk. CLEARTalk is one more initiative from Zydus, which encompasses one more facet unite against dyslipidemia. As you know that in India, 1.24 crores of Indian population is suffering with uncontrolled LDL cholesterol, and out of it, 7 out of 10 patients are having uncontrolled LDL cholesterol. So, a recent development in the field of dyslipidemia brings you bempedoic acid as an add-on choice for LDL cholesterol management, and hence this CLEARTalk is to clear all our doubts with our eminent speaker, Dr. S.K. Agarwal, sir. I would like to welcome you, sir, and to discuss the late-breaking CLEAR outcomes trials presented in ACC 2023 recently. And this season of CLEARTalk is focused on the more recent development the medical fraternity has witnessed. And this program is based on the objective of increasing awareness about the usage of bempedoic acid for all practicing physicians and general practitioners. So without wasting much of time, I would like to welcome Dr. S.K. Agarwal, sir. Thank you for being a part of this scientific feast called CLEARTalk. Over to you, sir.
Okay, so thank you so very much, dear Satish, for your kind introduction. Thanks to Zydus for inviting me for this important molecule, which recently got approved, of course, for management of hyperlipidemia. Already the drug was endorsed by ADA in 2022 for lowering the LDL cholesterol. So that was another milestone for this drug. But after the publication of CLEAR outcome trial, we have the robust data now to say that bempedoic acid not only reduces the LDL cholesterol, not only reduces the total cholesterol, not only reduces the HSCRP, the ApoB, but it also translates into the improvement in the hard outcome parameters, as has been demonstrated by the very important CLEAR outcome trial. In fact, we were expecting the trial results somewhere in the December 22, but it was presented in ACC recently, and I am sure majority of us must have gone through this trial because this adds to our armamentarium for improving the outcome in patients with hyperlipidemia. So can I have the first slide? We all know that the lipid abnormalities, the hyperlipidemia is one of the important risk factor for cardiovascular disease, and enough data from multiple trials, be it the primary prevention trial, be it the secondary prevention trial, we have enough data to support the use of statins, particularly in reducing the LDL cholesterol and in improving the outcome in patients with known cardiovascular disease or even for primary prevention. So definitely that is a very, very important parameter which we always assess in patients who are suspected to have CVD. And this is also a known fact that many of the patients, despite the recommendations for high dosage of statins whenever they are indicated, many of the patients do not achieve the recommended LDL cholesterol goals. Of course, the guidelines, keep on revising the LDL cholesterol goals, and the criteria are becoming more and more stringent, as we know the ESC 2016 guidelines, and if you compare with that ESC 2019 guidelines, and even if you see from our country the LAI guidelines, so they are going they are bringing the target LDL cholesterol levels lower and lower further down. So that's a very important. And at the same time, we also know that probably the statins are very effective in reducing the LDL cholesterol, but still probably majority of the patients, I can say almost 70% of the patients also do not reach to their target levels of LDL cholesterol. So then we were left with a big lacuna, which drug to use. Estimate, we knew that it's efficacious in reducing the LDL cholesterol, but probably did not improve the outcome in few other trials it was used. PCSK9 inhibitors, very robust data, significant improvement in the LDL cholesterol, and of course in the outcome also. But one was the injectable preparation, second was the cost. So that is how they did not penetrate as well as it could have been. So there was a big gap in the management of hyperlipidemia in patients where we wanted to use this drug for either primary prevention or secondary prevention. And this gap, of course, now has been filled up effectively to some extent by the bempedoic acid. So in my next few slides, I will be going through briefly like how the lipids are important, how many percent of patients do achieve the LDL recommended target levels, and how the bempedoic acid in CLEAR outcome trial have shown to be effective. So this is a very important trial. If you if you focus on this, the lower the LDL cholesterol, better is the long-term cardiovascular outcome, and longer you maintain the lower LDL cholesterol, you achieve the better outcome. So you see that each 1 millimole per liter, each 1 millimole is almost 38.7 milligram % reduction in the LDL cholesterol, gives more cardiovascular event reduction according to the number of years in trials and comorbid conditions as well. So if you see the first upper part of the trial, if there is 1 millimole reduction in the LDL cholesterol for 1 year, there is a 11% reduction in the relative risk of the cardiovascular event. And for longer duration, if you are reducing the LDL cholesterol by 1 millimole, there is incremental benefit. But this relation is not linear, of course. At 2 years, if you reduce it by 1 millimole, the risk reduction is 24%. Then, of course, between 3 to 5 years, the risk reduction goes to up to 33%. And for those who maintain this reduction for up to 6 years or more, there is up to 36% reduction in the relative risk of cardiovascular events. In the bottom half, if you see, in the bottom half, if you see, they have beautifully depicted like patients who have different risk factors. You can see the LDL cholesterol is one topic, and then after you have the cardiovascular disease with diabetes, cardiovascular disease with metabolic syndrome or impaired fasting glucose. Then you have cardiovascular disease without diabetes or metabolic syndrome. Then you have diabetic patients without CVD, and then the patients who don't have CVD or diabetes. So vertically, if you see the high level of LDL cholesterol, suppose you have a 5 millimole per liter LDL cholesterol, and if you compare it with the 1 millimole per liter LDL cholesterol, then what you find, 5-year risk of having a cardiovascular death or non-fatal MI or stroke. So a person who has CVD and diabetes, and if his LDL cholesterol is 1 millimole per liter, the risk over 5 years is only 10%. But if the LDL cholesterol is, say, 5 millimole per liter, then 5-year risk goes up to 62%. So there is a very clear single important parameter which affects the outcome is LDL cholesterol. So this is true across the spectrum, whether a patient has diabetes or he has metabolic syndrome or he doesn't have diabetes, only CVD, only diabetes with CVD. So you see across the spectrum, you find having a lower LDL cholesterol means better outcome. And as the LDL cholesterol goes from 1 millimole to 5 millimoles over 5 years, the risk increases by almost 5 to 6-fold. So that is how the lipids affect the outcome in a significant way. Next slide, please. Management of dyslipidemia is high on priority because enough data is there, and statins are the first line therapeutic agents. That is also very clearly a very clear recommendation, and we have enough data to support that. But still the important concerns are, do all statin users achieve LDL cholesterol goals as per guideline recommendation? That is one. Number two, how to achieve LDL target after maximally tolerated dose of statins have already been prescribed. So these are two very important concerns we have in our mind. Next, please. Let me see the first concern. Do all statin users achieve the LDL cholesterol goals as per guideline recommendation? Next. You see the different therapeutic agents which have been used to reduce the LDL cholesterol levels, starting from STMI 1 trial, the fibrates, we have 9 trials, niacin, the dietary recommendations. Statins, we have 25 trials, bile acid sequestrants, and finally the PCSK9 inhibitor. What we have noticed that each 1 millimole per liter reduction in LDL cholesterol is associated with 23% relative risk reduction of the cardiovascular events. So enough data is there. You see the PCSK9 inhibitors, you reduce the relative risk by almost 50%. because they are very potent drugs to reduce the LDL cholesterol. So 1 millimole per liter reduction in the LDL cholesterol is associated with 23% relative risk reduction of the cardiovascular events. So this is the data. Next, please. Target labels, when we talk about, you compare the two recommendations of ESC, that is what we had in 2016 and what we had in 2019. So the criteria are also becoming way more and more stringent to improve the outcome in these patients. In 2016, ESC recommended that in low-risk patients, the LDL cholesterol target should be less than 115, and same was true for the moderate-risk patient. In high-risk patients, they recommended LDL cholesterol to be brought down below 100 and very high-risk below 70. But after 3 years, they revised the guidelines, and the newer parameters were that low risk, keep the LDL below 115, moderate risk, bring it down below 100, high risk, bring down the LDL cholesterol below 70, and in very high risk category, you have to bring it down to below 55. So on one hand, we find that drugs may not be that effective, of course, but secondly, that all the recommendations, all the guidelines are also becoming very strict, and they are bringing down the LDL cholesterol further down to improve the outcome. Next, please. So how often do we find that the statins are effective in reducing the LDL cholesterol and in bringing down this to the target level? Next, please. So you have very important finding, that is the Da Vinci study. It was a cross-sectional observational study across the European Union. So in this observational study, 18 countries of Europe were involved, and total of 5,888 patients were evaluated for their lipid parameters and how they were taking the medications. So 3,000 patients belong to the primary prevention group, and close to 3,000 were for the secondary prevention, with an objective to evaluate the impact of ESC 2019 dyslipidemia management guideline on LDL cholesterol achievement. So you'll be surprised to note, next slide, please. Yeah. So if you see in the overall patient, if you see the dark red color where it's written 27.6%. So that is an important finding. Then in overall patients, only 26% of the eligible patients were receiving high intensity statin. So this is after 2019 recommendations of the ESC. So less than 1/3 of the eligible patients are getting high intensity statin. And even if they are getting the high intensity statin, only 30% of patients achieve the lipid goals with high intensity statin. So there is a huge gap. One, we probably do not prescribe the drug to those who require it. And secondly, even when we are prescribing, in the overall population across the Europe, we find that less than 1/3 of the patients actually reach to the target level. So this is into the all patients. Let me see the in high risk patients. Next slide. Similar observations are there in the high risk patients. Even in very high risk patients, only 37.5% of the eligible patients were getting high intensity statin, and only 22% of patients actually achieved the lipid goal with high intensity statin. So we need to say almost 20 to 30% of the patients who are getting the high intensity statin, even for primary prevention or secondary prevention group, we find that they achieve their LDL cholesterol goal, what is recommended. Next, please. So there is a huge gap, and this gap, how it is being filled up by the bempedoic acid, we will see from the clear outcome data. A little bit about the bempedoic acid before I go further onto this. This is a ATP citrate lyase inhibitor. This is a one step ahead before the HMG coenzyme A reductase inhibition, how the statins work. Half-life of bempedoic acid is 21 hours. Majority of the drug is excreted through the renal route. The drug is safe both for renally impaired and hepatically impaired patients. Of course, the drug has not been evaluated in end-stage renal disease and in the child book class C hepatic impairment, but overall the drug is safe in both the renal and hepatic impairment patients. There is some caution about the drug, that this drug is known to cause three important things. One, it increases the serum uric acid level. Two, it can precipitate gout in these patients, some patients, and there is some risk of tendon rupture with the bempedoic acid. So you have to keep in mind that whenever you are prescribing this drug, assess the serum uric acid as and when required, and even before the initiation of therapy. and keep a watch on the hyperuricemia and gout. And if any patient develops any joint inflammation, swelling, pain, or any chance of tendon rupture is there, one has to stop the drug immediately. One has to be careful in patients who are more than 60 years of age, patients who are taking the corticosteroids, patients who are on fluoroquinolones, those who have renal failure, and those who have a history of tendon rupture. So these are 5 important parameters which needs to be considered before prescribing the drug. And in case if a patient develops any tendon rupture or he develops a joint pain, swelling, or joint inflammation, one should discontinue the therapy and one need to reassess the patient. Another important point is that drug should not be given with simvastatin if simvastatin is more than 20 milligram or if the pravastatin is more than 40 milligram. But with other statins, that's not a problem. Pregnancy and lactation are the important contraindications for the use of the drug. So it should not be used in patients who are pregnant, who are likely to become pregnant, or who are lactating. So these are the few important points which we need to remember before prescribing the drugs. Next, please. So what is the CLEAR outcome trial? This is a late-breaking clinical trial which was presented in ACC 2023 last month. Next, please. So CLEAR outcome trial, it was in patients who did not achieve the LDL cholesterol. So LDL cholesterol was more than 100 milligram% in patient despite having the high intensity statin or those. It was basically in Bemdac was used in patients who are statin intolerant and they still had a elevated LDL cholesterol. So both primary and secondary prevention arms were included in the study. Statin intolerant patients were screened at before randomization, 5 weeks before randomization. Then there was a 4-week run-in period where the single band placebo was given, and finally the patients were divided into the active arm and the placebo arm. The active arm received the bempedoic acid 180 milligram per day. Total of 14,000, close to 40,000 patients were enrolled in the trial. 7,000 received the bempedoic acid, and another 7,000 were into the placebo arm. The regular monitoring was done at 1, 3, and 6 months, and after the telephonic contact was maintained with them, and then the clinic visit was further planned every 3 months. The end criteria, study completion criteria, were like when they will have a 1620, the primary composite 4-point MACE, or there would be 810 3-point MACE. And the treatment was supposed to be given for at least 2 years. The primary endpoint was 4-point MACE. That was a composite of cardiovascular death, non-fatal MI, non-fatal stroke, or need for coronary revascularization. So this was a primary composite endpoint, 4-point MACE. Median follow-up of that trial was 40.6 months. And the patients were supposed to take the drug at least for 2 years. Next, please. So if you see the baseline characteristics of the patients, demographic data, the 2 arms, the mean age was matching, 65 years, body mass index was slightly on the higher side, 30. The mean LDL cholesterol in both the arms was 139 milligram%. The HSCRP was matching at 2.3 milligram per liter. Majority of the patients had eGFR between 60 to 90, 62% of the patients, and 20% of the patients had eGFR less than 60. 30% of the patients were into the primary prevention arms, and 70% of the patients were into the secondary prevention arm. Coronary artery disease was present out of these 70% of the patients. 50% patients, 15% patients had cardiovascular, cerebrovascular disease, and 11% of the patients had peripheral arterial disease. And diabetes was present in half of the patients at 45%. Then statin use was there in 23% of the patients, and STMI was used in around 12% of the patients, 11.5% of patients. So that is the demographic profile, and that was matching very nicely into the 2 parts, whether the patient had on the active arm or into the placebo arm. Next, please. So how was the result? So important primary result was 4-point MACE. So there was a significant 13% reduction in the 4-point MACE. There was a significant 15% reduction in the 3-point MACE. The risk of myocardial infarction, be it the fatal or non-fatal MI, was reduced by a significant 23%, and need for coronary revascularization in the bempedoic arm was reduced by 19%. So these are the 4 important parameters which showed a significant reduction with the use of bempedoic acid in statin intolerant patients, be it was used for the primary prevention or secondary prevention in a large cohort of patients, approximately 14,000 patients who were enrolled between 2016 to 2019. Next slide, please. Next. So if you see the background, if not more, if not less than, at least 15% of the patients who are treated with the statin are intolerant. And if the patients do not tolerate statin properly, they fail to reach the target levels, and that is how they do not achieve the optimal cardiovascular benefit. Bempedoic acid, as I told you, it's an important ATP citrate lyase inhibitor, is the mechanism of action. CV outcome was not assessed before the availability of this CLEAR outcome trial, but we had multiple CLEAR trials with the bempedoic acid. The important one was the phase 3 trials were like important was CLEAR Harmony, CLEAR Wisdom, CLEAR Serenity, and Tranquility. So CLEAR Harmony was like into the 2,500 patients or so, and that has clearly established, all these 4 trials, in fact, phase 3 trials have clearly established that the bempedoic acid on an average reduced the LDL cholesterol by 20%. And not only LDL cholesterol, there was a significant reduction in the HSCRP, the total cholesterol, the ApoB, and the non-HDL cholesterol with the use of bempedoic acid. So we had enough data that bempedoic acid is effective in reducing the LDL cholesterol and HSCRP, but we did not have the data that it improved the outcome also, and that is what is available from the CLEAR outcome, just as I have mentioned. 13% reduction in the primary composite 4-point MACE, 15% in the 3-point MACE, 23% reduction in the fatal and non-fatal MI, and 19% reduction in the coronary revascularization with the use of bempedoic acid. Next, please. So primary and key secondary endpoints, we have already discussed. The primary endpoint was 4-point MACE, which included the cardiovascular death, non-fatal MI, non-fatal stroke, and coronary revascularization. Then, of course, there was a hierarchical testing for key secondary endpoints, and this was into the descending order, like 3-point MACE, fatal and non-fatal MI, the coronary revascularization, then, of course, the fatal and non-fatal stroke, then cardiovascular death, and all-cause mortality. So these were the important secondary endpoints in the sequential manner they were tested. Next, please. So we have already discussed this. There was a 13% significant reduction in the 4-point MACE, 15% significant reduction in the 3-point MACE, 23% significant reduction in the fatal and non-fatal myocardial infarction, and there was a significant 19% reduction in the coronary revascularization with the use of bempedoic acid in CLEAR outcome trial. Overall, if you see, there was a 21.7% reduction in the LDL cholesterol with the use of bempedoic acid, and you will be surprised to see that the reduction in the LDL cholesterol in comparison to placebo was evident at 12 weeks or even before. And that was the data which was well established from other CLEAR trials also, even in the CLEAR Harmony and CLEAR Wisdom also, and be the Serenity or Tranquility. We know that the reduction in the LDL cholesterol was evident to the tune of approximately 20% within 12 weeks of initiation of therapy. Coming to the HSCRP, again, in line with the other CLEAR trials, the CLEAR outcome also demonstrated a 22% reduction in the HSCRP, and the reduction was prominent even from the initial 6 months, and which persisted over the follow-up period of 40.6 months. So there is not only a reduction in the LDL cholesterol, there is also a significant reduction in the HSCRP with the use of bempedoic acid. Next, please. Coming to the safety analysis, I have already mentioned 2 or 3 important parameters which need to be concerned are the hyperuricemia. So you can see the third last into this slide. Hyperuricemia was noted in 10.9% of the patients with bempedoic acid versus 5.6% in the placebo. The gout incidence was also increased, 3.1% in bempedoic acid versus 2.1% in patients with in placebo arm. Other parameters, other side effects were almost same in the 2 groups. The serious adverse events were same. The adverse events leading to discontinuation of therapy were same. There is no increase in myalgia, which is very common with the statins, of course. So as far as the myalgia is concerned, that's not a problem with the use of bempedoic acid. There is no risk of increase in the incidence of diabetes mellitus with this drug. There is no increased renal impairment with this drug. So only 2 important considerations which I mentioned is the hyperuricemia, gout, and of course the tendon rupture and inflammation. Next, please. So if we conclude, clear outcome study have clearly demonstrated that bempedoic acid is the first ACL inhibitor and first oral non-statin therapy to demonstrate a statistically significant reduction in the primary composite endpoint of 4-point MACE in patients with or who are at high risk of cardiovascular disease with documented statin intolerance and elevated LDL cholesterol. So this is a very clear message from clear outcome data. Next, please. So to conclude, bempedoic acid is an effective alternative for statin intolerant patients. As has been demonstrated by clear outcome trial, it's a well tolerated in a mixed population of primary and secondary prevention patients who are unable or unwilling to take a statin. There is a significant, close to 20% reduction in the LDL cholesterol and HSCRP. Then there is the benefits are across the spectrum, be it the patient is having primary prevention or secondary prevention, and not only the primary composite endpoint, even the important secondary endpoints like 3-point MACE, MI, and coronary revascularization was significantly reduced. And it's an effective approach to reduce the major cardiovascular events in statin intolerant patients. Next, please. So I think this is all for my presentation, and thank you so very much, my dear friends, for patient sharing. And Mr. Satish, now maybe we can have some discussion and we can take up the questions for the clarification. Thank you so very much.
Thank you so much, sir. Such a crisp and very well concluded presentation. There are few questions which have come in the online link which we have. So this first question is, like you initially said, that ESC 2019 guidelines, many patients have uncontrolled LDL cholesterol, but they don't have any complication. So should I increase the dose of statin or to add bempedoic acid or ezetimibe in these patients to achieve those ESC 2019 guideline recommended LDL cholesterol goals?
No, actually, it's not like that. You have to go for a scoring. You have to see whether the patient belongs into the low risk category, whether he belongs to moderate risk, whether he belongs to high risk category, or he belongs to extremely high risk category. So on the basis of those parameters only, and then there is a score. So then you have to decide like what could be the LDL cholesterol goal for that patient. Then the statin remains the primary mode of therapy. You start suppose a patient falls into the extreme high risk category, you give him the highest dose of the statins, rosuvastatin 40 milligram or atorvastatin 80 milligram, assess the LDL cholesterol after 3 months. And if you find that the target levels have not been met, then you will need to add the bempedoic acid in those patients. So if you are giving the maximum dosage, still you are not reaching the target levels, or if you are not able to tolerate, the patient is not tolerating because of the myalgia or some other side effects, then probably you need to add these drugs.
Thank you so much. Thank you so much. The second question is, I have many patients with type 2 diabetes and hypertension. So what LDL cholesterol target should I keep for these patients? That is a general question which has been asked. And in line to this question, is it appropriate to keep LDL cholesterol below 40 milligram as per guideline recommendations? Can it lead to any neurological complications? That was
even if you see the LAI recommendations now, and if you see for the extremely high risk category, they have divided into type A and type B. So type B falls into the category where like patient had a repeat myocardial infarction within 1 year, and some other points are there. So these are the patients who require an LDL cholesterol even below 35, even below 30. So the recommendations, like, it depends upon the risk criteria, how many risk criteria a patient is fulfilling. So different guidelines have got slightly different approach. Like even I mentioned ESC 2019, the very high risk category, they are bringing the LDL cholesterol to below 55. LAI is recommending even below 30 now. So it depends upon, like, it's not a generalization. Diabetes or hypertension, so any patient who has diabetes, like he will fall into the, if it is more than 5 years or so he will fall into the high risk category. You have to bring it down below 70. If he is into the very high, maybe you have to bring it down to below 55. So it's like that.
Okay, sir. Thank you, sir. Thank you very much. The next question which has come on the screen is, if patient is having elevated LDL cholesterol with moderate statin dose, then what should we do? Like either whether we should increase the dose of statin or add bempedoic acid. That is what the question.
Yeah. So see, recommendations are still, if the patient is tolerating well statin, there is no side effect with the statin, then probably I will go for increase in the dose of the statin. If he does not tolerate, then only I will go for either the bempedoic acid or the estimab. Bempedoic acid will be a preferred agent over the estimab in my opinion.
Okay, sir. Thank you, sir. Thank you so much. The next question is, what percentage of LDL cholesterol reduction is observed with bempedoic acid in clinical practice you have seen? You must have prescribed to number of patients. So what percentage of LDL cholesterol
It's
reduction?
too early to say, but if you go by the clear data and at least 5 important trials we have with the bempedoic acid, as I mentioned, the clear harmony, clear wisdom, clear serenity, tranquility, and now the outcome. So overall reduction in the LDL cholesterol with the drug has been close to around 20 to 25%. So 21.7%, you can take a figure like if you are using, because it's a single dose drug. It's not like you have to increase it again. 180 milligram of the bempedoic acid has to be given once a day with or without food. That then makes much difference. So with one single dose, on an average, there is a reduction in the LDL cholesterol by 21.7%, you can say.
Okay. And there is one question, interesting question, that how long we have to wait in patients who are to see uncontrolled LDL cholesterol to add the second drug and third drug in line.
So recommendation is start the therapy, reassess the LDL cholesterol after 6 to 12 weeks. So maybe you can say that you can continue the therapy for 12 weeks at the most, and if still the goals are not met, then you can add the second or third drug.
And do you recommend the patient who have undergone PCI bempedoic acid?
A good question, I will say. Too early to comment upon this parameter, but of course, if the cholesterol goals are not met, actually you see that there is a difference into the Indian population from the Western population also, I will say here. We often get a very good result from the statins such far the LDL cholesterol reduction is concerned. So provided if I find that the patients are not improving, there are some set of patients, maybe the familial hyperlipidemia, some patients, of course, do come in our practice where the LDL cholesterols are very high and probably they are not responding to the statin therapy as they should. Then the bempedoic acid is a very, very handy tool to prescribe them. Majority of Indian populations, of course, do respond very nicely to statin therapy, but only problem is intolerance, because of many of them will complain of fatigue and myalgia. So these are the patients where we have to reduce the dose of the statins, or maybe we have to sometimes completely stop the drug. So in those scenarios, of course, we have now this drug which have a proven efficacy as far as the outcome parameters are concerned.
Sir, just now you spoke about statin intolerance. How frequently statin intolerance do you observe in your routine practice?
Definitely, if I say not much, I will say at least 5% of the patients do complain of statin. Of course, the data, if you say almost 10 to 15%, they will mention from the Western population. But I think in my clinical practice, I will keep the figure somewhere close to 5%.
Yes, there's one more interesting question which has been asked is, as per clinical trial data, is it more beneficial to use bempedoic acid in pre-diabetes patients to delay new onset of diabetes mellitus?
Not really. I can't say that it's a recommendation to use the bempedoic acid for pre-diabetic patients to delay the diabetes. That's not the correct statement in my wisdom, I will say. Because we know that almost 4% of patients on statin may develop over diabetes mellitus, and majority of these patients, of course, do have impaired fasting sugar or they are pre-diabetic. So that is a group of patients where the diabetes may get manifested with the use of this statin. But if you see the bempedoic acid, we have clear data that bempedoic acid does not increases the fasting or postprandial glucose levels. There is no increase in the HbA1c level. and there is no increase in the risk of diabetes mellitus with this drug. So only when the lipid lowering therapy is indicated and you have to use, and if a patient is into the pre-diabetic range, so it's not that all of them will develop the over diabetes. Only 4% is the overall population who develops diabetes with the, but still even in that population, the benefit risk ratio, if you assess, it is much in favor of statins. Even in those patients, the statin should be continued, but only if the patient develops over diabetes, then sometimes you may have to cut down the dose of the statin, and that may be the one region where you can add the bempedoic acid.
Thank you, sir. Thank you so much. This was the last question. There's no further questions, but would like to have your final comments on the entire session and take-home message to all our delegates.
Okay. So what I started in the beginning, that LDL cholesterol has to be targeted for reducing the cardiovascular events. They have to be targeted very hard. We have to stick to the recommendations and guidelines. Of course, they are bringing down the LDL cholesterol level below and below and low and low. Statins remain the #1 drug, and they are very useful in improving the outcome in these patients. But a significant proportion of the patients who do not tolerate or who do not reach to the target level, we had a big lacuna which drug to use, because estimab has been shown to improve the LDL cholesterol, but probably the efficacy is not that well demonstrated. So we have a drug now in our hand, which not only reduces the LDL cholesterol, which not only will bring many of these patients to the target levels, but will also improve the outcome. So a combination of the statin with bempedoic acid, and if needed, even the estimab, can be prescribed in these patients. If you see the combination of the three drugs, you might be knowing, moderate intensity lipids, statins, they reduce the LDL cholesterol by 30%. High intensity lipid statins reduce the LDL cholesterol by 50%. If you combine it with high intensity statin with estimab with bempedoic acid, there is almost 65 to 70% reduction in the LDL cholesterol level. So it's not like that they are not competing. Two drugs are not competing with each other. They are in fact providing a synergistic action whenever they are needed. So we are with a very good drug which could be useful in the given scenario.
Thank you so much, sir, for having you here in this evening, and the experience and expertise you have shared must have helped all our delegates online who have joined in their day-to-day clinical practice. Definitely, this will definitely help them, and use of bempedoic acid to achieve LDL cholesterol and in the management of dyslipidemia. And from Zydus Life Sciences side, would like to help. Thank you so much for your presence and expertise. I would like to thank all the delegates online who are online for your patience listening and your active participation. So without your active participation, this program could have been passive message for each one of us. Thank you, sir. Thank you, and have a good day and good evening. Thank you so much for joining this Clear Talk.
Thank you. Thank you so much. Thanks to all my dear friends who joined me today evening. And I wish you all a very pleasant day, a pleasant evening. Have a nice time. Good night.
Thank you, sir. Bye-bye. Take care. Bye.